Hey folks, I wanted to give you guys an overview of the emergency approach to abdominal pain. Abdominal pain will represent a huge portion of the number of patients you'll be seeing, and getting a good algorithmic approach to abdominal pain is a very good idea from the get-go. As always, any lecture produced by me is available free to you and to modify for any future use, as long as you attribute the original owners. Pathophysiologically, you've probably seen this slide before last year. Abdominal pain comes in different phases. You'll see this especially in appendicitis, where you have visceral pain fibers causing vague sensations in the early stages of illness. And then you have peritoneal pain at the later stage when the pain migrates to the right lower quadrant. And that's more localized to a dermatome and to a more localized area. The embryology sort of determines where you feel pain in these cases. And sort of we go over foregut, midgut, and hindgut. And that sort of corresponds to embryological distinctions on where pain would be in the visceral state. Your history generally follows the standard OPQRST. Know your history sheets well. One of them will be attached to this lecture. And you should also know all of the associated symptoms well, and that includes anything associated with, the GU, gynecologic, vascular, cardiac in some cases. So you need to ask all the associated symptoms just to make sure you don't miss anything. Also know your locations. This often will determine what investigations you order and if you actually find what you're looking for. Diverticulitis, left lower quadrant, but in Asia, often right lower quadrant. Appendicitis, periumbilical, and then migrates to the right lower quadrant. Biliary colic, cholycystitis, it's often in the right upper quadrant. Pancreatitis, epigastric or periumbilical, and often radiates to the back. Peptic ulcer disease is mostly epigastric and sort of a burning pain. So to get to know these location-based diagnoses, and you should be served very well. Associated symptoms, nausea and vomiting. This will often clue you into the volume status of the patient. Do you need to give this patient fluids? Fever and chills, a cue that antibiotics might be necessary, and also increases the likelihood of appendicitis or cholecystitis or UTI or pyelonephritis being present. Ask about bowel movement patterns. Is the patient constipated? Is it really constipation or is it an obstruction? Is there presence of diarrhea? Is there melena? Hematochezia. Always ask about UTI symptoms, frequency, urgency, hematuria, etc. And always ask about gynecologic symptoms, especially in women. Is there dyspareunia or painful sexual intercourse? Is there vaginal discharge? Is there lower pelvic pain? Also ask males, do you have any urethral discharge? Awkward topics, often you'll have to excuse visiting family members because people will not be straight with you, but very important to ask. Like I mentioned before, always take a full gynecologic history, last menstrual period, pregnancy, previous history of STDs. Obviously less important in men when you're asking about pregnancy. Past surgical history, often when you ask a patient if they have any medical problems, they will not consider surgical problems as one of those. Often even looking at the abdomen will reveal scars, and you can ask patients those questions. And ask, about peritoneal symptoms on history, like pain when walking or when driving over a bump, etc.
Differential diagnosis, you can find this in just the facts page 144. Most of the time, when you examine abdominal pain, you won't find a definite diagnosis. And in this case, close follow-up is needed. These are a list of other conditions: appendicitis, biliary tract disease, bowel obstruction, etc. And you should know generally how to manage and recognize these conditions.
Elderly patients are often at increased risk of biliary disease, ischemic disease. They have a higher mortality for almost everything. They have higher admission and complication rates, and reliable history and physical exams are difficult and often absent. You have to be very careful. Things will present often atypically, often even without pain, and finding these things puts an increased reliance on lab tests and imaging. Physical exam, the most important part, along with your history, is check your vital signs. Is the patient tachycardic? Are they febrile? Check postural vitals. That will give you a valuable clue on if the patient is volume depleted or if they're bleeding. Inspection. Is the abdomen distended? Are there scars? Is there ecchymosis, such as the Gray-Turner sign? Auscultation. Are bowel sounds present or absent? Is there renal bruit present? Palpation. Is there rebound tenderness? That's a peritoneal sign. Is there guarding? Is there organomegaly? Do you feel a large spleen? Do you feel a liver edge? Hernias. Very important in cases of bowel obstruction. Is the patient strangulating an incisional hernia? Also, rectal exams, important in the cases of rectal bleeding. Also, if you're looking for masses, if you're checking for appendicitis in some rare cases. A pelvic exam, important in women with pelvic pain or vaginal discharge, or in who you suspect pelvic inflammatory disease. A testicular exam, always important in men who complain of pain in that region. Lab tests, an increased white count is non-specific, but it does give you a higher likelihood ratio for pathology such as appendicitis or cholycystitis. 28% of patients with raised white counts will not have a definite diagnosis. A urinalysis, blood in the urine indicates renal colic, but 10% can be negative. Pus in the urine, as in white blood cells, can indicate a UTI, but that can also be present with pelvic inflammatory disease, or if any inflammatory mass is next to the ureter, like appendicitis. Other tests, amylase lipase. Lipase is more sensitive, but this is useful for looking for appendicitis. Beta HCG, pregnancy, electrolytes, volume depletion, etc. Creatinine, renal function, liver function tests like AST, ALT, INR PTT, useful for coagulation factors, an alternative test of liver synthetic function because the liver produces your clotting factors, and in cirrhotic patients you'll often have a raised INR. And also an ECG cardiac enzymes, which is useful in patients with risk factors with epigastric pain because that is often a way in which cardiac ischemia presents. Imaging. Plain radiographs are useful in cases of obstruction or perforation. Sometimes ischemia, renal colic, you're looking for a stone on a KUB, and foreign bodies. Your occasional child eating a coin, or in some cases a cocaine packer straight from the airport. That's always interesting. Ultrasound is useful for biliary tract diseases, renal disease, but can miss small renal stones, so not the best for renal colic, but good for renal abscesses, etc. Pelvic pathology in women, you can get a good transvaginal ultrasound and visualize the ovaries, look for Doppler flow of the ovaries if you're looking at ovarian torsion, and looking at ascites if you're looking for a place to tap ascites, and also useful in the emergency setting for people like me if you're looking for if someone has a lot of intra-abdominal bleeding, if there's ruptured AAA, if there's a pericardial effusion, but that's a separate topic. CT is better generally for trauma. A AAA that's leaking, if there's leaking blood, if you're suspecting a fistula, aortoenteric fistula for instance, it's better for pancreatitis, it's better for renal colic, it's better for diverticulitis and appendicitis. The tests for all of them except the renal colic are done with contrast, whereas the renal colic test is not done with contrast. And that's it.